ठीक है क्या टाइम क्यों नहीं हुआ अभी तक? नॉर्मल करो ना, स्टार्ट हो गया। हाँ सर ये स्टार्ट।
वो पहला वाला क्लास अभी तो हर थर्सडे हो रही है, वो डीएनबी का ही है, नेशनल बोर्ड क्लास कराते हैं। ये कोई और दूसरा रेडियोलॉजी ग्रुप का, रेडिएशन ऑन्कोलॉजी ग्रुप का है, वो स्टूडेंट्स के लिए क्लास लेते हैं, वो कभी कभार ही होती है। Nasopharyngeal carcinoma.
Good evening. Good evening, Asim. Good evening, Asim या Komal. Is it possible for people who are not talking to be muted? Because we can hear a lot of opinions.
मैं देखा अपॉइंटमेंट देने लगा जेसी भी ना हुआ जेसी बना लीजिए मेरी फिर मैंने कहा जेसी बना देख लो मैंने वो मेरा के प्रॉब्लम पूछना होगा कोई था नहीं डब्ल्यूएमडी है ठीक करेंगे अगर किसी का प्लान लीड कर दे कमेंट भी
आप तो मैं देखी ना मेरी स्थिति इनको मना करा था
ये वेटिंग रूम Good evening everyone. So welcome to Mahamana case. I'd like to request Dr. Shwetabh Sinha. So today's session is on nasopharyngeal carcinoma. And I'll request Dr. Shwetabh Sinha, he's Assistant Professor of Radiation Oncology. He will be speaking upon the importance of radiotherapy in head and neck cancer. Shwetabh, are you there?
Yeah, I am there. Am I audible, Asif?
Yes, you are audible. Can you please share your screen?
Yes.
Sorry, Shweta, 1 minute before you start.
Yes.
Asim, can you please request everybody who is not speaking to mute their mic?
Yeah,
It's causing a lot of disturbance.
सर को बस अनम्यूट कर दीजिए ये जो Shweta, you can please start. Okay. And I'll request everyone to please keep their mic on muted if they are not speaking.
Okay.
Only the presenters and the moderators can unmute themselves.
Okay. So good evening, everyone. I hope I am audible clearly. So I will be speaking on the general principles of radiation therapy for head and neck cancers. Before I start, a general disclaimer that this discussion is primarily meant for the surgeons and the head and neck surgical oncologists. So a few of the things the radiation oncologists may find a little bit more basic, but as I was told that this is primarily meant for the surgical crowd, so I have tried to stick to the basics. So, as we all know, so the efficacy of radiation therapy in malignant cells and tumor cells was established as early as 1895, and it was well known that radiation has the potential to kill the tumor cells. And subsequently, multiple experiments started. A lot of work was done in Europe, and finally, it was well established that radiation is a therapeutic modality for treating cancer. Here you can see this is the picture of a boy, a 2-year-old boy treated with ailing from retinoblastoma, who's treated with radiation on the first ever linear accelerator. This is in 1956. The boy went on to live a long life with intact vision, and this actually earmarked this was actually one of the landmarks in radiation therapy for killing cancer cells. The modern linear accelerator, which we currently use now, equipped with IMRT, was established in 1999. So how does radiation act? We all know that radiation acts by causing double-stranded and single-stranded DNA breaks. I think that is one of the basics that we are all well aware of. And this happens by the direct action where the photons, which are nothing but packets of energy, they enter the DNA double strand and cause these breaks. And these photons can actually interact with the tissue inside the body, and this leads to subsequent free radical regeneration, and these free radicals also cause DNA damage. So this is the indirect action of radiation. So due to the direct and indirect action of radiation, the tumor cells die. So why does the radiation kill the malignant cells preferentially? This is a question that is often asked, and this the answer lies in the fact due to its basic mechanism. We know that RT is acting on the DNAs, right? And the malignant cells have a higher proliferation potential. They spend a lot of proportion of their life cycle in the G2M phase. Now, this G2M phase is highly reliant on the structural integrity of DNA. So we can imagine if an agent is damaging the DNA, like radiation therapy or even chemotherapy, the malignant cells which have a higher proliferation potential and spend their maximum part of their life cycle in the G2M phase, they will be affected more, and subsequently this leads to the cell kill. However, even the normal cells are proliferating, and this is the reason why we see the side effects with radiotherapy and chemotherapy. So this is just about the synergistic action of concurrent chemotherapy. Concurrent chemotherapy does increase the efficacy of the radiation therapy. It enhances the tumoricidal potential of radiotherapy. But as you can see here, when we add concurrent chemotherapy, even the side effects increases due to the DNA cross-link formation and change in the DNA repair enzyme mechanism conformations. So yes, concurrent chemotherapy increases the efficacy, but also it increases the toxicity. So the goals of radiation treatment for head and neck cancers are similar to what other curative treatments have to do. We have to maximize disease control, we have to prolong survival, we have to avoid toxicity, and we have to improve quality of life. So this is pretty standard. I think surgery, chemotherapy also have this similar mechanism of action. So this is a classical graph which is associated with radiotherapy that you will often see. This is called something called as the tumor control and the NTCP graph. So on the y-axis, you will see there are percentages. These percentages denote the probability of controlling the tumor, that is the TCP, and the probability of causing damage to the normal tissue, that is called as NTCP, normal tissue control probability. On the x-axis, you will see the doses. Here you see 3 doses, A, B, and C. So at the dose level A, so we see that the tumor normal tissue complication probability is 0, but even the tumor control probability is not much. It is only 10%. Whereas at dose level C, you can see the tumor control probability is really high. It is to the tune of 90%. But if you see, the normal tissue complication rates are also high. So we have to strive for the maximum separation between these two lines. On the left side, we have the TCP. On the right side, we have NTCP, and we have to choose. And we have to choose a dose where the separation is maximum between these two lines. So this comes to around 60 to 70 gray for head and neck cancers, and this is the dose level where we play around when we are talking about radiation therapy for head and neck cancers. So by modality, radiation therapy can be divided into EBRT, which is more than 90 to 95% of the radiation therapy we see, especially for head and neck cancers. And brachytherapy is quite less utilized in head and neck cancer. We'll talk about it. And by intent, of course, it can be curative or palliative. Within the curative subset, we have adjuvant radiation that is delivered after surgery, or the definitive radiation where surgery is not a part of the multimodality treatment. So coming to the external beam radiation therapy, I think it is one of the most, radiation oncology is one of the most technologically intensive branch. We have seen a lot of technological evolutions, ranging right from the first LINAC, which was started in 1960s, to the modern linear accelerators, proton therapy, and heavy ion therapy. So we'll go through some of these. I think most of you would have heard that there are two types of machines which we commonly use in our clinical practice. One is the older machine, that is the telecobalt, and the newer machine, that is the linear accelerator. The linear accelerator is on your right side. So basic difference, a linear accelerator uses artificial energy source, artificial radioactive source. And of course, it is much more flexible. It can produce a variety of energy, 6 MV, 10 MV, 15 MV, etc. It can do a lot more complex planning like 3D CRT and IMRT. And no source change is required, and there is no problem of source disposal also. Whereas cobalt is the older machine, it is preferred only for simpler treatments. There is no much flexibility, but of course, it is much less resource intensive and cost intensive. So briefly about concept of targets and organs at risk. So when in radiation oncology, we always talk about our tumor volumes and targets. So this you can see the case of CA oropharynx. So in the green, if you see, we have delineated something called as GTV, which is called as gross tumor volume, which is nothing but the clinically, radiologically visible tumor. So we have just delineated it with on our treatment planning system. So you can see this is the GTV. Sorry. If you notice very carefully in the SAM, we have actually given it the GTV a margin of 5 millimeter, and that actually is for accounting for all the subclinical and microscopic disease which is not visible with our naked eye. So this SAM volume is actually the clinical target volume. And here, if you see, we have given a further 5 millimeter margin to the CTV, which is called as the planning treatment volume, which is to account for the setup uncertainties and organ motion and all other certain such things. So we have typically 3 targets: GTV, CTV, PTV. Typically, PTV is the biggest one, and our dose is prescribed to this PTV. Head and neck has some really important organs at risk, damage to which leads to significant toxicity and much inferior quality of life. The important of them are spinal cord, brainstem, carotids, and the dysphagia respiration related structure, which are nothing but the constrictor muscles and the cricopharyngeal inlet. So you can see, besides delineating the target on our CT scan, we also have to delineate the OARs like this, and we have to specify in our treatment planning system that we want to give this amount of dose to this target, whereas we want to spare this organ from this much of dose. So for example, I can say to my treatment planning system, I want to deliver a dose of 70 gray to this red PTV, and I want to spare the I want to give maximally only a dose of 45 gray to the spinal cord. So spinal cord should not receive more than 45 gray in any condition. So this is how we do our radiation oncology planning. So techniques of RT, our techniques of RT have evolved. So you can see earlier days, we used to treat a lot of normal tissue surrounding the target. As and when the planning evolved, we moved from 2D planning to 3D planning. You can see our target coverage becoming much more conformal, and we were able to spare much more of normal tissue. And this you can see is the current era, which is the era of IMRT. We can beautifully target the tumor, and we can actually spare a large amount of organ surface surrounding the tissue, surrounding the tumor. This is primarily doable due to the availability of something called as multi-leaf collimator and complex software algorithms with the modern treatment planning system. So you can see the beams can be divided into small beamlets, intensity of which can be modulated. And this is what we call as intensity modulated radiotherapy, giving us such beautiful dose distributions. So actually, Tata Memorial Hospital has a rich history of IMRT for head and neck cancers. We were part of 2 seminal randomized trials in late 2010s comparing 3D CRT and IMRT for head and neck cancers. Both of these trials established IMRT as a standard of care in head and neck cancers. Here again, you can see, if you see this again in CA oropharynx, you can see in the older techniques, we were firing a lot of parotids, oral cavity, even spinal cord. When we moved to 3D conformal radiotherapy, some part of it was spared. But in today's modern IMRT, you can see almost the entire non-overlapping parotid, oral cavity, and brainstem and the spinal cord is getting spared. So IMRT is considered as a standard of care in head and neck cancers for sparing and dysphagia aspiration related structures. There is level 1 evidence for this. And for treating tumors in critical locations in head and neck like nasopharynx and paranasal sinus, IMRT may actually improve local control and survival by its ability to deliver higher doses to the tumor without exceeding the tolerance of critical normal structures in the vicinity like brainstem and spinal cord. So coming to a little bit about fractionation. So what we commonly use in our day-to-day practice is something called as conventional fractionation. It is usually delivered 1 fraction per day. The doses are really in the range of 1.8 to 2.2 gray per fraction. So they are delivered for 30 to 35 fractions, enabling us to reach doses as high as 65 to 70 gray. So they are delivered 5 days in a week, the conventional fractionation, with Saturday, Sunday being a holiday. And each session lasts for about 15-20 minutes. So in head and neck, most of the times we end up using conventional fractionation for our curative intent patients. But any deviation from this is called as altered fractionation. Altered fractionation are 3: hyper, hypo, and accelerated. I will not go into much detail about all these altered fractionation regimes, just to drive the fact that all these altered fractionation can increase the efficacy of conventional RT. For example, in accelerated radiotherapy treatments, we can actually decrease the overall treatment time by giving the RT 6 days in a week instead of 5 days, and this can actually improve the loco-regional control rates. Similarly, in hypofractionation, we can deliver higher dose per fraction, and this will helps us in treating radio-resistant tumors such as those found in salivary glands or even in paranasal sinus region. So RT doses, I have somewhat discussed already. So when we are treating gross tumor, as in when surgery is not done and we are treating gross intact tumor, doses in the range of 66 to 70 gray are required in conventional fractionation. So the treatment lasts for around 6 to 7 weeks or 30 to 35 fractions. If we are treating microscopic disease, such as when you guys have operated and there is risk of microscopic disease left behind, then we go to doses of around 60 gray. And when we are treating sites which were not actually involved by the disease, but are at risk of subclinical disease and subsequent chances of relapse are there, we go to doses of 50 to 54 gray. So you can see the doses are decreasing with the burden of tumor. That has to be anticipated. So timing of RT, some seminal randomized trials in 1990s have established that it is very important to start adjuvant RT at around 4 to 6 weeks after surgery. That actually helps in improving the loco-regional control rates. And also, once the RT has started, it is ideal to finish the radiotherapy within 6 to 7 weeks. So unplanned treatment gaps due to machine breakdowns and toxicity are not at all desirable, and they may lead to inferior outcomes with radiotherapy. So some special considerations, we know that radiation therapy is associated with a lot of side effects and toxicity. So before the RT starting, we refer our patients for dental prophylaxis. We actually advise our patients to see the speech swallowing therapist before starting RT and during RT. Dietitian assessment is essential, and any other chronic ailment should be judged by the physician. Precautions during RT, we advise our patients to maintain an adequate oral hygiene. Salt and soda gargles are advised 10 to 12 times in a day. They are advised to keep the local area clean, but they can have daily bath. They have to avoid shaving, rubbing, and scrubbing of the irradiated area, and they have to maintain adequate nutrition and avoid weight loss during RT. So this is the basic background of radiation therapy that may be essential for the surgeons. And now coming to some management of some common cancers from the radiation oncology point of view. So as we are aware of this, the general principle in head and neck cancer is that early stage cancer, that is stage 1 and stage 2 cancers, are managed by a single modality that can be either surgery or radiotherapy, whereas in loco-regionally advanced tumors, multimodality treatment incorporating surgery, radiation, and chemotherapy is required. So coming quickly to the oral cavity cancers, this is the management algorithm for oral cancers. Stage 1 and stage 2 cancers are managed by a single modality that can be surgery or RT, whereas advanced cancer requires surgery first and post-operative radiotherapy with the addition of concurrent chemotherapy in high-risk patients. So surgery is the preferred single modality for majority of stage 1 to oral cancers. RT is only considered as a single definitive modality in early cancers when surgery is morbid or functionally disabling. The patient is either medically inoperable or there is patient refusal. So then in such cases, radiation therapy can either be EBRT or brachytherapy. Coming very quickly to brachytherapy for early oral cancers, it is preferred in proliferative lip and angle of mouth growths or even in buccal mucosa growths. And the lesion has to be away from the bone. The patient has to be clinico-radiologically node negative. Some superficial hard palate lesions are also suitable for brachytherapy. It is a minor OT procedure, at least the brachytherapy for the interstitial brachytherapy for the lip and angle of mouth, and the patient requires to be admitted for 10 days. While brachytherapy is an extremely efficient modality for loco-regional control, the only caveat is that we should be extremely sure that these patients have minimal risk of nodal metastasis, as brachytherapy doesn't address the neck nodes as compared to surgery or even EBRT. And in certain patients, brachytherapy can be combined with EBRT after EBRT given as a boost. So coming to the advanced cancers, after surgery, adjuvant EBRT is indicated for high-risk features like positive margins and extranodal spread, and for intermediate risk factors like closed margins, extensive PNI, more than one node, and P3T4 disease. So these are all fairly standard risk factors for adjuvant RT. Concurrent chemotherapy we add for gross extracapsular extension and positive margins. The current standard of care for concurrent chemotherapy is either weekly cisplatin at 40 mg per meter square or 3 weekly cisplatin at 100 mg per meter square. So lastly, in oral cavity, coming something to definitive CTRT for oral cancers, there is limited experience with it. It is reserved for patients with unresectable disease in good performance status, but it can be technically challenging delivering such high doses to large lesions in oral cavity due to risk of toxicity such as mucositis. And the outcomes are not bad, but a two-year OS of 10 to 30% are reported. So a select group of patients may do okay with definitive CTRT for oral cancer, but it is definitely not the preferred treatment, and surgery should be the preferred treatment wherever feasible. So this is how we contour for our oral cancers. You can see this is a patient who has undergone a bite composite resection, and here in the green you can see this is our clinical target volume. We have incorporated the entire flap, a part of the resected bone, and the other surrounding tissues. And in the blue you can see we have also treating the level 1B and 2 nodes electively. So our target volumes for oral cavity cancers are similar to the principles of surgery. Besides the primary tumor, we address the level 1B, 2, and 3 in all cases, and sometimes even level 4A is included in cases of heavy nodal burden. So coming to oropharyngeal cancers, if you look at the P16 negative oropharyngeal cancers, the NCCN guidelines actually prefers definitive RT or CTRT for both early and advanced stages. Surgery can be considered for selected early tumor. This is the NCCN guidelines. Whereas for P16 positive oropharyngeal cancers, actually the NCCN guidelines says that both TORS and RT or CTRT are equivalent options for early stage cancers, whereas for advanced stage cancers, still CTRT is preferred. So as we know that in India, the incidence of P16 positive oropharyngeal cancers is less, but it is on the rise now. Recently a meta-analysis has shown this to be around 50 to 25%. So there is a thrust for de-escalation of radiotherapy in these P16 positive oropharyngeal cancers, largely because of the better biology, their increased responsiveness to radiation therapy, and their possibly longer survival. So we want to decrease the toxicity as far as possible, and this has given rise to certain trials of de-escalation of radiation therapy in these cancers. Most of these are ongoing and are in experimental phase. There is no definite established it has not been established that any of these de-escalation strategies are safe, particularly in a phase 3 setting, but still they can be considered. What has been definitely established is that cetuximab cannot be replaced by cisplatin when given with CTRT for even for low risk HPV positive oropharyngeal cancer. So this is primarily ruled out. But de-escalation of RT doses, we can omit the primary post TORS and treat only the neck. And even reduction in doses of RT are being considered. So again, this is a raging debate about surgery versus radiation therapy for low risk p16 positive oropharyngeal cancer. There are a couple of randomized trials, and then there is also the ECOG trial, which actually established the safety and efficacy of TORS and adjuvant therapy as a good treatment regimen for these cancers. What can be taken together from all these trials together is that TORS is a suitable option for selected early low risk HPV positive oropharyngeal cancers, and that if the patients are treated with a single modality, that is either surgery or radiation therapy, they end up with more or less a good quality of life. The patients who end up with multimodality therapy, that is surgery and adjuvant CTRT, are the patients who have worse quality of life. So we should select our patients appropriately for any of these treatments. And what is another point that is essential is that surgical expertise is essential when you are dealing with TORS. So this has come out of these 2 or 3 major randomized trials. Coming to our target volumes for oropharyngeal cancers, besides the GTV, we have to address the level 2, level 3, and level 4 nodes. And in patients where the posterior pharyngeal wall is involved, we even have to address the retropharyngeal nodes. So this is how an IMRT for a oropharynx cancers looks like. You can see the volumes can be quite large, and significant toxicities can be associated with it. Coming to larynx and hypopharynx, these are the NCCN guidelines. So the thrust is on organ preservation. As far as possible, organ preservation should be considered either with CTRT or even with organ preserving surgeries wherever the expertise is available. So if you look at the NCCN guidelines for T1, 2, 3, N0 to N3, CTRT or RT are considered good options. Also, organ preserving surgeries are recommended. Salvage laryngectomy is should be reserved for such patients, and extensive follow-up is definitely required when we are doing organ preservation strategies. Patient with gross cartilage destruction and upfront dysfunctional larynx should undergo upfront laryngectomy. There is no doubt about it, and we have seen in our series of patients also that doing definitely CTRT in these patients may lead to inferior outcomes, even if you reserve the laryngectomy in the salvage setting. And neoadjuvant chemotherapy can be considered in some patients, particularly for hypopharyngeal cancers, which largely owing to the high rates of distant metastasis as well as their possibly better response rates. So coming in brief to T1 glottic cancers, this is another debate that is always there between surgery and RT, and this is there are 2 randomized trials, and this is one of those long-term results of one of those randomized trials, and you can see that the outcomes or the long-term outcomes in terms of locoregional control and survival are similar between surgery and RT. And patient, it all depends on the patient preference and the available expertise. So the target volumes for laryngeal and hypopharyngeal cancers, besides the primary, we end up treating the level 2, 3, and 4 nodes. Besides in hypopharyngeal cancers extending downwards to the upper esophagus, we end up also treating the upper mediastinal nodes. And in laryngeal cancers, the pre-laryngeal nodes are also included. So this is how the volumes of IMRT looks like for laryngeal and hypopharyngeal cancers. You can see always it is bilateral. In most cases, it is bilateral irradiation, and a large part is irradiated. Nasopharyngeal cancers will be discussed subsequently in detail, so I'll be very brief about it. RT is the mainstay for treatment. We all know. So for most treatment, it is either the definitive part is either CTRT or RT, and this can be clubbed with either neoadjuvant chemotherapy or adjuvant chemotherapy. An interesting paradigm in nasopharyngeal cancer is the oligometastatic and oligoprogressive disease, which have shown good response rate and even survival with the combination of chemotherapy plus SBRT or local RT to the metastatic site, as well as treatment of the primary site and the node. So these are our target volumes. I think Shakti will discuss it in much better detail. So for RT, rehabilitation and follow-up is essential. RT is associated with a lot of grade 3, grade 4 toxicities. Even with modern IMRT, approximately 30%, one-third of our patients experience grade 3 toxicities. These include dermatitis, mucositis, and dysphagia. These are the primarily bothersome for the patients. But it is the stridor and aspiration which are actually the life-threatening complications during CTRT. And I'm sure you all are aware that we sometimes end up doing emergency and elective tracheostomy during the CTRT for head and neck cancers. So what we all must be very aware of these two toxicities during when a patient of head and neck cancer is receiving RT, and as soon as we suspect these, appropriate intervention should be done. Long-term toxicities, approximately again, one-third of patients have significant sequelae of RT. These include xerostomia, dysphagia, hypothyroidism, osteoadenocrosis, subcutaneous fibrosis. Approximately one-third of patients can be on long-term feeding tube dependence, depending on the site of the primary as well as the type of radiation received. So these are some pictures of the radiation-induced toxicity. You can see this is the dermatitis, which begins at around 3rd to 4th week and subsequently peaks at around 5 weeks and then subsequently heals. This is a picture of mucositis during CTRT, and this is a picture of osteoadenocrosis. So rehabilitation, it is always multidisciplinary. We have to take help from a lot of our colleagues to ensure that all the survivors of head and neck cancer patients have a good quality of life. We should refer our head and neck cancer patients on follow-up to dental colleagues, to occupational therapists, to speech following therapists, and even to the dietitian. And chronic lymphedema is one of the most worrisome complications of RT for head and neck cancers, and this may sometimes require a referral to dedicated lymphedema clinics for complete decompression therapy. Follow post-RT follows the similar principles like surgery. We usually follow these patients 3 monthly for the first 2 years and 6 monthly thereafter. These are as per standard guidelines also. Clinical examination and site-directed endoscopy are done at each follow-up. And what is different about definitive CTRT is that PET-CT is considered as the standard of care post CTRT. So it has to be done at 10 to 12 weeks post CTRT. And this is largely from this seminal randomized trial from the UK. This is the PETNIC study, which demonstrated that radiation therapy, that PET-CT actually has more than 99% negative predictive value for detecting persistent disease, particularly in the nodes, and this may spare a significant proportion of patients from necessary neck dissections and salvage surgeries. So very quickly about brachytherapy. Brachy means short in Greek, and here in contrast to external beam radiotherapy, the radioactive source is placed in the vicinity of the tumor directly. And a very conformal, and the advantage of brachytherapy over external beam radiotherapy is that the dose can be very conformal. So we can deliver really high amount of doses to the tumor without actually damaging any other normal tissue, because the radioactive source is actually placed in the vicinity of the tumor. The disadvantage of brachytherapy is that not all sites of the body and even in head and neck are not feasible for brachytherapy, and only a small volume can be treated with brachytherapy. So in head and neck, we can do intracavitary brachytherapy for nasopharyngeal cancers. Interstitial means placing the radioactive sources within the bulk of the tumor, and as we do in lip and oral cancers. And we can do some surface mold brachytherapy for superficial skin malignancies as well as hard palate tumors. So you can see this is a BCC of the nose treated with surface mold brachytherapy, and you can see this patient has excellent cosmosis, and even the patient remained disease-free for at least 5 years till the time the patient followed up. This is another surface mold brachytherapy for a tumor of the pinna. And this is a lip brachytherapy where we did interstitial implant, and you can see this is the patient 3 months after follow-up with good cosmosis and good functional outcomes and no recurrence of disease. So very quickly, interstitial brachytherapy is a minor OT procedure. It requires roughly around 30 to 45 minutes. These needles are inserted within the tumor, and subsequently these needles are replaced by catheters, and these catheters are daily connected to a radioactive source, which is housed inside this machine. The source travels via these channels to inside the tumor. delivers the desired dose, and then comes back and rests inside this machine. So the patient requires to be admitted for 7 to 10 days in the ward, and 2 fractions of brachytherapy are delivered daily. So finally, coming to my last 2 slides, certain special considerations. Radiotherapy is an extremely effective modality for palliation for head and neck cancers, particularly for bleeding and fungating masses. A single shot of high dose radiotherapy, such as 8 gray or even 10 gray, or even short courses of high dose radiotherapy like 20 gray in 5 fraction, can lead to really good palliation and give these patients a very effective quality of life. So we should always remember that while in curative setting, radiotherapy has a role, perhaps in palliative setting, the role of radiotherapy can be even more important. And finally, coming to proton therapy, I'm sure a lot of buzz is going around proton therapy in the recent times. We at TMC Mumbai are about to start our proton therapy unit in the next 2 to 3 weeks. So basically, proton therapy takes the sparing of normal tissues to the next level. You can see here, this is a patient of, again, of oropharyngeal cancer. You can see here that on the top is the IMPT plan, which is nothing but the intensity modulated proton therapy. And on the bottom, you can see it is the IMRT plan, which is the current standard of care. You can see in the blue, there is a significant amount of low dose fill in the oral cavity and posterior regions, particularly in the spinal cord. So with IMPT, we are able to further spare these normal tissue from the low dose fill. So particularly useful in areas such as skull base and nasopharynx, which are located near the critical structure, and perhaps which have a long-term survival, with, probably due to its potential to reduce the late toxic effects. So yes, proton therapy definitely is one of the major developments in radiation therapy for head and neck cancers, and it continues to evolve, and in future it may have a role to play in a major role to play in the head and neck treatment landscape in India also. Thank you. I'll be happy to take any questions. Hello. Hello, am I on?
You can join in as the examiner for the case discussion as well. And whenever there is a question or anything similar to your topic, we can then discuss along with that.
Sure.
And now I'll request the case presentation session to start. I'll request for this, we have moderators. We have Professor Sarbani, Ghosh, Laskar, Professor of Radiation Oncology at Tata Memorial Hospital, Mumbai. Dr. Prathamesh Pai, Professor of Head and Neck Surgery at Tata Memorial Hospital, Mumbai. Dr. Sheetal, Raina, Senior Advisor and ENT Consultant at Head and Neck Oncology Wing, Command Hospital, Lucknow. And Dr. Sambit Nanda, he is Assistant Professor of Radiation Oncology at our center, that is Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi. And I'd request Dr. Shaktivel Mani, he is a resident at the Tata Memorial Hospital, Mumbai, to start the case presentation. Do we have all the examiners?
Yes, Asim, I'm there.
Yeah, I am here.
Okay.
I'm here too.
Thank you, sir. Welcome, sir.
Yeah, so am I audible?
Yes, yes.
Okay, so I'll start with my case discussion. Good evening, everyone. So
can you please share your screen?
One second.
Yeah.
Is it visible, my screen?
Yes, yes.
My screen is visible, right?
No, we can see you, not your screen. So your presentation is not visible.
One second. Now? Is it visible now?
You've just started sharing. You just started sharing, so we'll see it.
Is it visible now?
Yes, it is visible. You may start.
Yeah. So good evening. I'll be discussing a case of CA nasopharynx. So to start
Shakti,
with,
1 minute. Yeah.
Okay, to start with, so this is a case of an 18-year-old boy from West Bengal who came with complaints of nasal obstruction and swelling from both sides of his neck for the past 3 months. And he had no history of any diplopia, blurring of vision, hoarseness of voice, dysphagia. In terms of habits, he was smoking BD for the past 4 years, which is upsetting, and no comorbidities as such. And general examination was a good, moderately well-built individual. His oral cavity had tobacco-stained teeth, but no visualization. On neck, he had a right neck swelling, which was more prominent than the left, which was around 5 cross 5 centimeters in size. It was fixed to the underlying structure. On the left side is approximately 2 centimeters in size. On a neurological examination, there was no cranial nerve deficit or any neurological deficit as such, and a DNA was done. It showed a left-sided.
Well, 1 minute. Go back to your history.
Yes.
Hello.
Yes, sir.
Yeah, go back to your history slide. Yeah, so that's all you're taken in your history.
Yeah, from his place and his occupation, he was studying in school, and he was a college-going boy, and
okay,
this was the chief complaint.
So you're going to ask any other history?
So then,
what is your impression only on history?
my history, I also just try to rule out tuberculosis, any fever or any infectious
Where
cause.
is your history?
Yes, sir. History of any infection or fever as such.
No. What is your impression based on this?
Based on history, he has a cervical nodal mass, which needs to be evaluated further.
Okay, and what about the nasal block? You want to characterize that further?
Yes, we would have to characterize this one further. But his predominant symptom was nasal block and the swelling. So when we saw him, first would be the swelling, on which we would have to further look at.
Okay. So what else? What are you thinking? What case is this?
It's an 18, it could be, I could think of multiple differentials from an infectious cause. Then if he had a history of fever, a night sweat, then we could have thought of lymphoma because of his age group as his nodal mass.
Right.
And then third could be another more solid tumor, could be another third option in this scenario.
Okay. So we need to ask the rate of growth. Since you just said nasal blockage in 6 months.
Yes, sir.
We need to characterize that further. Swelling over both sides of necks in 3 months. Has it increased, decreased? Okay, so you need to ask further history. You cannot just say that this is all that I will ask. Okay, go ahead.
One more thing that I want to say is whether the nasal blockage was unilateral or from both sides, whether there was any anosmia associated with it or any bleeding associated. So these history needs to be taken alongside of the nasal blockage.
Okay.
Shakti, you also need to characterize the kind of nasal thing, what you call, the nasal thing they've talked about. So typically what we do in the OPD, Shakti, you've not documented, but I'm sure we do it. And you need to just say that, we have history of what you call tinnitus, fullness in the ear, a chronic thing, what you call otitis media kind of symptoms. Yeah, and hearing loss, some patients present with that. So that is what, and also signs and symptoms suggestive of any kind of cranial nerve deficit. All right. So what we ask for in any visual deficits that we may have. All right.
Yes, ma'am. Okay. Moving on to my next slide. So for a general examination, he was a moderately built and nourished individual. on the most prominent thing was the neck. So we started with the neck examination with right level 2-3 was a large palpable nodal mass 5 cross 5 centimeters in size, which was fixed to the underlying structures, firmly adherent. And the left side also there was a palpable node, 2 cross 2 centimeters, just firm. It's also there. We did a neurological oral cavity. We could not visualize any lesion as such. And in the neurological examination, there was no sign of any cranial nerve palsy or neurological deficit. And an endoscopy finding from the history, there was a left-sided nasopharyngeal mass, which was, yes, you can add finding of bleeding, and this was something which I can add to the bleeding also. And can I go to the next slide? Okay. So we investigated this patient further. Along with the DNA, a biopsy was done. Which showed a undifferentiated nasopharyngeal carcinoma, and based on which we did a serum EBV titers as well, which was EBV positive with 12.7 copies. To assess the local disease extent, we preferred an MRI of the face and neck with the paranasal sinuses as well, and an FDG PET CT for a metastatic workup. Since we already had a diagnosis of a nasopharyngeal primary ulnar, we usually do a routine baseline workup as a PTA, ophthal, and a thyroid function test for these patients. And after that, we did if you see the MRI patient, it was a 3.9 into 2.9 into 3.2 centimeter lesion in the nasopharynx. It involves both the fossa of Rosenmiller and eustachian tube. Anteriorly, it had intracranial extension. Posteriorly, the slight indenting and involving clivus. And then superiorly, if you can see, it was a subtle erosion of the floor of the sigmoid sinus can be seen. There was no intracranial extension as such. Inferiorly, oropharynx, no extension into the oropharynx. And then laterally, it was abutting the pharyngobasilar fissure and levator panettone. It was not extending beyond the medial pterygoid or the lateral pterygoid. So to describe the local
Shakti,
extent.
I'll just request you stop here. So there are students on the call, and I'd like to ask them, after whatever Shakti has presented, is there anything else that you want to do? Shakti, I don't want you to answer. Is there anything else that you would like to do or you would like to evaluate besides what Shakti has already told you? There, Asim, can you point out the students, because we don't know who the students are? Any takers? Yeah.
In our hall, as well as radiation therapy students. I mean,
yeah.
Dr.
So I would like them to ask and answer whether they think whatever Shakti has done so far is enough, or do they need to have any more information? Because he's going to come up with other radiological investigations. But so far, whatever has been done, is that adequate, or do you want anything more?
Pan endoscopy can be done.
Yeah, so he's already told you on mapping what they have found. So is there anything else that you would have achieved by doing any other kind of endoscopic evaluation? Is there any other evaluation? So one you're saying is do a more detailed endoscopic evaluation. Is that what you said? I don't know who it was, but yes, yeah. Yeah, so I think Shakti, you did report the mapping of the disease, right?
Yes, ma'am.
Yeah. No, not here. You did talk about what was the extent of the disease initially, the mucosal examination. Didn't you? You were saying something about the disease being. So what has been suggested is that possibly you may want to do a proper endoscopic evaluation to kind of document the extent of disease as far as the mucosal involvement is concerned. Is that right?
Yes, ma'am.
Yeah.
Yeah. Okay. Anything else? So do you think what he has done so far? Yeah, please go ahead. Somebody is saying something.
Ma'am, we would like to go ahead with the whole body FDG PET scan.
Pardon?
Whole body FDG PET scan.
Okay, fine. Thank you. Thank you. So now, Shakti, will you go on to say what you did next after the MRI with the disease extent as you've discovered, as you've described? What was found on the FDG PET CT scan?
So on the FDG PET, it
Go on
again
to show you.
describes
Move your slides. Move your slides.
Can you see my slides, ma'am? Can you all see my slides?
Yes, we can.
Are my slides visible? Yeah.
Yes, yes, it's visible.
Yeah. So I'll describe. So the PET, you could see the primary nasopharyngeal mass, and then slowly you can see the level 2 retropharyngeal nodes as well. If you notice, the bulk of the nodes are predominantly on the right, level 2, 3, and the left as well. The predominant bulk, as his complaints were mainly on the right side, with the right-sided nodal mass, which was extending to level 4, level 5 on the right side, and extending beyond the cricoid as well. And there were no distant mets in this patient. Okay. Anyone has any question or anyone?
Sakti, I just want to ask that since we have done already MRI, what was the need to do the PET-CT in this case?
So one of you will have to answer. Shakti will not answer this question. One of you will have to answer why you think in a nasopharynx in an 18-year-old man, you have done an MRI which includes the face and the neck. I'm sorry, I don't know who asked that question, but I want one of the students to, unless it's one of the moderators. I hope it was not Sambit.
Ma'am, it's me, Sambit.
Okay, sorry. I don't want Sambit to answer that question. I want one of the students to answer that question as to why, despite having done an MRI of the face and upper neck, we still did a PET-CT in this patient, young male, who presented with bilateral neck nodes and this mass in the nasal cavity and the nasopharynx. So will one of the students volunteer to answer that question?
Ma'am, for a case of nasopharyngeal carcinoma, the main mode of spread, first would be like mucosal spread that we are documenting with 0-degree endoscopy. For the local extent, we are doing MRI. And for the regional and distant spread, we need to get a PET scan because nasopharynx also can land up with distant metastasis even at baseline.
Yes. So what is the incidence of
percentage.
distant metastasis? What is the incidence of distant metastasis in a patient of nasopharyngeal cancer at presentation?
I think, ma'am, at locally advanced diseases, around 20 to 20%.
So you have to answer this question in terms of the stage at presentation, and it is also a function of the nodal disease that you have, right? And the histology of the growth. Okay. So then, will somebody else take up this question to answer? Sambit, please go ahead and ask your question.
Now I want any of the resident to give the answer that does MRI give any information which is over and above what we get from the PET-CT?
I can answer. Please answer. Perineural invasion, sir. Intracranial extension and perineural invasion will be better delineated in the MRI compared to PET-CT.
Who's this who's talking about perineural invasion in nasopharyngeal cancer? Where would it be important, especially in what kind of nasopharyngeal cancer would you look for perineural invasion? In which particular type of nasopharyngeal cancer would you be interested in looking specifically for perineural? Yes, yes.
Cystic variant, ma'am.
Yes, yes. So in nasopharyngeal cancer, I would put it a little differently. So how would you put it for nasopharyngeal cancer? You're correct. You're looking for perineural, but what are you looking for essentially? For disease spreading through the?
Or all the foramen and the skull.
Yes, the base skull foramina, right?
Yes, yes.
Yeah.
Okay. Good evening, Sarbani ma'am. I just wanted to ask the resident, what are the routes of spread to the intracranial region? Be it adenoid cystic or be it NPC. In your case, since you have discussed about NPC, what are the routes of spread? So you're talking about perineural, excellent, but it is the way of spread from which all foramen? You talk about skull base foramen. Which foramen is the one which is vulnerable for a perineural spread?
So for foramen ovale, lacerum, foramen rotundum, from the
Can we have the other speakers muted, please? One is foramen ovale, yes. Other ones?
Foramen lacerum, foramen rotundum, and yes, it can go to the pterygomaxillary fissure, pterygopatin fossa, and from there with the rotundum to the intracranial spread can happen. Then the cavernous sinus spread
Primarily,
can also be
intracranial
there.
spread is either the paras cavernous sinus or the foramen ovale.
Yeah. Yes.
Of course,
yes.
it can invade the orbit and go along the lines, but primarily for adenoid cystic, it is the foramen ovale and the all right.
So
Sarbani ma'am was asking about the indication of an upfront PET CT in an 18-year-old child. We all know that NPC has a bimodal presentation. You can have kids as young as 11, 13, 14, and as old as 60, 70, 80. So what was the indication upfront for a PET CT following an MR when you realize that it's just a local regional disease? Interestingly, the disease was on the left nasopharynx. The bulkier nodes were on the right, level 4 and 5. Can you explain?
Me?
Dr. Mani.
Yeah, so basically, if you actually look at it, the mass is more centralized in the nasopharynx. You can't left, right, and nasopharynx can spread bilaterally to both bilateral nodes. So in that sense, I would still get a PET done in this case, because if such a high clinically multiple nodes are palpable, we would still get a PET CT done to rule out the disease. And this one for the primary to know the local extent, and MRI would be a better imaging modality in this scenario.
Yes, but
so somebody.
Yes, sir.
So somebody did answer correctly right in the beginning, saying that the essential utility of PET in this stage of nasopharyngeal cancer, because Sambit asked this question, and I think somebody did answer right in the beginning that it is essentially to know the regional extent of disease and distant metastasis, essentially because of the kind of presentation you're seeing in this patient. So you've got local disease. That local disease is answered by the MRI mostly. It's the regional extent of disease that the PET will give you additional information on. And of course, most importantly in this young boy, who's got so much of neck disease, you also want to know whether he has any distant disease, right? So now will one of the trainees there tell me what are the most common locations of distant metastasis in order of what do you call frequency? Pardon, bones, lung, and liver. And you have to always be specific that this is for undifferentiated kind of nasopharyngeal cancer, right? Okay, fine. So can we go ahead, Sheetal and Sambit?
Yes, ma'am.
Yes, ma'am.
Yeah, chalo. Yeah, chalo. Aage, Shakti.
Yes, ma'am. So we've with our imaging and finding, we've diagnosed him as a case of, say, nasopharynx, T3N3, and treatment plan for him would be neoadjuvant chemotherapy followed by definitive CTRT. The neoadjuvant chemotherapy regimen in this patient was 3 cycles.
1 minute. Shakti, wait. Don't jump the gun. 1 minute. So now we've got lots of trainees here. So you said T3N3M0. So what would be your plan for treatment? Now Shakti has given you the answer as to what we did. Now forget that. For a minute, forget what he said. So what will be the approach to this patient? T3N3 non-metastatic nasopharyngeal cancer in an 18-year-old male. You've got all the information you need to decide on management. Would you agree, all the trainees on the call? Yes or no? Quickly, because we're running out of time. Okay, so now one of you volunteer to say I want one of the radiation oncology trainees here to say what would be the pattern of management. What would you want to do for this patient?
Neoadjuvant chemotherapy followed by CTRT.
And what is the evidence for this? Huh? There's somebody who's speaking, there's a lot of echo. What is the evidence to use neoadjuvant chemotherapy followed by chemoradiotherapy in this stage of nasopharyngeal cancer?
Ma'am, for locally advanced nasopharyngeal cancers, we have evidence from the SUNY University group, and they have basically run 2 groups of trial. One was with a TPF, 3 cycles of TPF followed by CTRT, and I think they got a 3-year PFS of around 80%. And they have also done the GEMSIS trial, also was from the same university, because I think they were using that for the palliative treatment, and then they started using that for NSCT.
Okay.
And they got a 3-year PFS of 85% with GEMSIS.
So you have two large randomized trials telling you that you have evidence to suggest or rather support neoadjuvant chemotherapy followed by chemoradiotherapy. Now, what is the premise for using neoadjuvant chemotherapy?
The premise is that that there is a lot of distant metastasis that happens in nasopharyngeal cancer, just with only locoregional therapy or with adjuvant therapy, adjuvant chemotherapy. The rate of distant metastasis is somewhere around 20 to 30%. Just so, like micromets are happening at the beginning. So to diminish that, we are using NSCT upfront and then going ahead with the CTRT treatment.
Okay. Now I want somebody else to answer what is the other advantage of using neoadjuvant chemotherapy. Sambit and Sheetal, please feel free to butt in.
Surely,
Yes,
ma'am.
Shwetabh, yeah, please butt in whenever you want to. Yeah, please go ahead. So what's the other premise for using neoadjuvant chemotherapy?
T3 disease will be close to the skull base, not exactly invading, but it will be close to the skull base. So if we give NSCT upfront, then it will decrease the field of RT field which will be given after NSCT.
And can you back this up with any kind of evidence?
So T3 disease here is because of invasion of sphenoid sinus, PNS. I don't think this disease is extensive barring the nodes.
So tell me, now how will you counter what Dr. Raina is telling you? Counter this, you're saying that by giving neoadjuvant chemotherapy, you will reduce the volumes of radiotherapy. And Dr. Raina is telling you that is not a concern here in this patient because this is T3 disease. So how will you counter this? Whoever said that statement. Okay, so we will take your point, but we'll keep it for afterwards. Anybody else?
Ma'am, and one question that I want to ask, that what is the most important critical organ at risk, from which point of view you want to reduce the...
You tell me the answer. You ask me. I'm not exam going. I'm not exam going. You have to answer this question. When do you think? Yeah, tell us. Yes.
Any of the resident can answer.
Orbit.
Orbit. Can you be more specific?
Particularly the lens and the
pituitary gland.
1 minute. 1 minute. Where is the lens located? Anteriorly, posteriorly, close to the nasopharynx, in the nasopharynx. Will somebody help her out? Is it the lens? Is it the orbit? Is it the entire, whatever, I don't know what region that would be called. What particular structures are you worried about? Yes. And?
Optic nerve is the most important.
And?
Optic chiasm.
And?
Optic chiasm.
And okay, you'll have said optic nerves, optic chiasm.
Pituitary gland. Pituitary gland.
Pituitary gland. You're worried about the pituitary gland. Okay. What else would be more critical in the nasopharynx?
What is just behind the pharynx, nasopharynx?
Now this Dr. Raina has given you too much of a clue.
Spinal cord.
This carotid.
Spinal cord. Who said spinal cord? Abhi anatomy class mein wapas bhejna padega. What is more critical there? Just behind the nasopharynx.
Carotid arteries.
Are bhaiya, where is the brainstem located?
Carotids are lateral. They are in the
Somebody call
paranasopharyngeal space.
Now, finally, ma'am has to give the answer to get it out of here.
No, somebody called Amina answered right, but then you all have to think about it logically. Do you have a thing, what you call a third year? No, na? Sambit, you'll have just started. So this will all be first year, right? And second year.
Yes.
Yeah, okay, fine. So now should we go ahead, Sambit?
But this is ma'am anatomy question. So anyway, they have to also.
Yeah, you're correct there. Okay, should we go ahead then? But you know,
Yes,
you all have not answered this question about neoadjuvant chemotherapy completely. Because there have been several trials that have been done with the use of neoadjuvant chemotherapy before we had this trial from Sun. And all the studies so far had shown that neoadjuvant chemotherapy was not useful as far as overall survival was concerned. And that was essentially because most of these studies were done as neoadjuvant chemotherapy followed by radiotherapy alone. Later on, there were 5 trials done, which were phase 2 studies. And the best thing about these studies was that they proved that when you had to intensify treatment with the use of systemic therapy, if you did it the neoadjuvant followed by CTRT, then the tolerance was better, the compliance was better, and the ability for patients to complete treatment was much higher than the one that was practiced by people in the practice-changing trial of Al-Saraf. So that is how you have to say. So you had the Al-Saraf study, which actually brought in concurrent CTRT plus adjuvant versus radiotherapy alone. Later on, you had studies that looked at neoadjuvant chemotherapy followed by CTRT, and then which showed the time to event time to event occurrences was better. And then, of course, CTRT remained the mainstay of treatment. It was only after the trials from the Sun Yat-sen that showed that you should do neoadjuvant followed by CTRT. And that is what, kind of made a place for this regime, particularly in the treatment of nasopharyngeal cancers. Okay. So now can somebody tell me what are the different regimes for neoadjuvant chemotherapy? Somebody has already told you, so you just have to repeat that.
PPF and Genesis.
Pardon?
Genesis, ma'am.
Okay, and?
PPF.
And DCF you said? Okay, fine. So which regime will you choose for which patient? Is there anything for that? What do you do at your institute? I can't hear very clearly. Sambit, can you just, I don't know if you can ask them and see what they're saying. I can't really hear them very clearly.
Ma'am, they're discussing amongst themselves and coming to a consensus.
Okay. So what are the different regimes? Somebody said GemCis and the other regime was DCF, right? So which one will you choose? Is there any evidence to suggest that you choose one over the other? What do you do at your institute?
I'm DCF, 3 weekly DCF, 3 cycles.
So all patients with nasopharyngeal cancers get DCF. Are you sure about that? What do you think, which regime will be better tolerated with less toxicity?
So what ma'am is asking is, which of these 2 regimens is more toxic and which one is better tolerated?
DCF is more toxic compared to GemCis.
Very good. So there is one randomized trial actually looking at the 2. It's not a real big paper, but then it definitely shows that the two regimes are equally effective, but the GemCis regime has better tolerability. Okay. So that's why we've now gone the neoadjuvant way. But what is the pivotal treatment for locally advanced nasopharyngeal cancer? Can somebody answer that? Sorry, Shakti, to have stopped you, but I thought the purpose was to, because I realized that the purpose is to discuss the case. And of course, then Shakti will wind it up with his thing with a short presentation. But yes, now come on, tell me, what is the pivotal treatment for loco-regionally advanced nasopharyngeal cancer? Can one of the surgeons answer this question? See, as surgeons also you need to know, because you need to know when you have to refer the patient across to the radiation oncologist and the medical oncologist, right? So tell me, what is the pivotal treatment in this stage of nasopharyngeal cancer? You've given neoadjuvant chemotherapy, then you've assessed response. Next, what will you do?
In other words, what's the gold standard?
CTRT.
Very good. So CTRT you said. So now radiation oncologist, come on, we're going to be asking you. So we'll just wait for Shakti to go on with what we did with this patient. Shakti, go on.
Yeah. So going on
Just,
with
Shakti, just 1 minute. I want
Yeah.
to ask the radiation oncology team, what are the treatment options that we have enumerated as of now? Ma'am has already told you about the options. So can someone tell me what are the treatment options as of today? And we'll go for the evidence later on and final conclusion later on. Don't go to the jump to this, what was done in this case. Tell me the options which are available, and then we'll go to the final conclusion.
CTRT followed by adjuvant chemo.
Yeah, one option. Next.
Early stage definitive RT alone. Even
Definitive RT alone, is that an option as of today? Already this case is T3 N3 M0.
So we're talking about this case and not given T2 early disease. This is T3,
No,
T3 N3.
for this case. Yeah, for
Stage
this case.
4. Neoadjuvant chemotherapy followed by chemoradiation or definitive chemotherapy followed by adjuvant chemo.
Definitive chemoradiation followed by adjuvant chemo. So you have got two options. One third option is definitive.
If there is an option of chemoradiation with brachy boost.
Wonderful. Who gave this answer? Now let me ask you. You know why? Because you also have surgeons. So you have to be very clear when you answer this, when you give this option of chemoradiation followed by brachy boost. Now, what is the challenge to giving a brachy boost in this particular case?
My node was big.
You had a T3 N3 disease. That means, in effect, both your primary and your nodal region needs to receive the full dose, right?
Yes, ma'am.
When you talk about only a brachy boost, what about the dose that you're going to be giving the neck? And then how will you then account for the doses at your primary and then dealing with the antecedent toxicity of your treatment? See, you're not wrong. You're not wrong. I will tell you, I will come to that answer that I want to hear, but I will tell you what you're talking about. So, you know, typically what she has said is not wrong, but in this patient who has T3, N3, M0 disease, you will have to give the neck the full dose. You will have to give the primary the full dose. Now, when you have to do that, it would typically mean that you've treated the entire disease, preferably with external beam radiotherapy, simply because you don't want to exceed tolerances anywhere. And today, with the use of IMRT, you can easily do it. Today, the role of brachytherapy boost in nasopharyngeal cancers is actually limited to patients who may have residual disease at first follow-up, or where you cannot do IMRT and give the full dose to the primary tumor. Is that clear? Because
absolutely,
unfortunately, yeah. So unfortunately, in nasopharyngeal cancer, when you're doing brachytherapy, in addition, see, when you're doing brachytherapy for nasopharyngeal cancers, your tolerance organs there are not your brain stem or your optic nerves, it is the palate. If you give a high dose to the nasopharynx, you also end up giving a very high dose to the palate. And you have to take account of that because that will result in significant morbidity. So today the role of brachytherapy is relegated to those patients in whom you don't have access to IMRT and you cannot give the full dose that is necessary to control your primary disease. All right, clear? So as Sambit said, you all have given the options. You have neoadjuvant chemotherapy followed by chemoradiotherapy. You have chemoradiotherapy followed by adjuvant radiotherapy. And in some cases, you may consider doing neoadjuvant chemotherapy followed by RT alone, but that proportion of patients is very small. Sambit, is there any other option you were thinking of?
No, ma'am. I wanted to get these three answers from them.
Ma'am, in fact, I wanted to ask, which is that subset of patients where you will give neoadjuvant and only RT?
So would one of you want to answer that question? So, I think Sheetal, today, we've reserved that essentially for those patients who are not candidates for concurrent CTRT. Now, most often, this group of patients will also be that group of patients who will not be candidates for neoadjuvant chemotherapy. But you do have some patients who have had significant toxicity to neoadjuvant chemotherapy, and you have to end up giving only radiotherapy. And this most often is the elderly subgroup of patients.
Or with renal morbidities.
Yes, yes. So let us allow Shakti to go ahead with this complete case then. Yeah, Shakti, what happened finally with this patient at TMH? Hi Shakti, are you there?
Yes.
Yeah.
After he completed his 3 cycles of chemo, we do a response assessment scan. There was a decrease in the nasopharyngeal primary mass with a slight decrease in nodal burden on an MRI. And then we went ahead with to planning with definitive radiotherapy along with chemotherapy to a dose of 70 gray in 35 fractions to the primary and the involved nodes, and intermediate risk volume to the primary at 63/35 and to the uninvolved nodes at 56 in 35 fractions, along with concurrent cisplatin weekly.
Okay, so Shakti, just stop here. Shakti, stop here. So now I want one of the radiation oncologists to tell me, who's one of the trainees here, to tell me, you have decided that now post NACT, in view of the favorable response, we are going to do concurrent chemoradiotherapy. Would you be able to describe what we are going to be doing right now? Okay, Shakti, go ahead. Unless somebody is going to say. Is somebody going to say? Shakti, go ahead. Shakti, go, yeah.
So we take a planning CT scan, a neck neutral position, preferably use a 5 clamp off it so that the head is well mobilized, and this based on availability. Side thermoplastic mold with 3 fiducials at the glabella along with an IV contrast enhanced CT scan of 2.5 mm thickness will be a planning simulation scan. And for contouring, we fuse the CT and the MRI, and delineation happens on the MRI. And after delineating on the MRI, we reconfirm it on the CT scan. And after that, we give and as per the institutional protocol, we give a PTV margin, and we evaluate the patient through as per the ICRU guidelines of high risk volume receives 95% of 70 gray. And the
Shakti, wait, Shakti, wait. Go back. Bas wait here. So have you all seen this process being done in the department?
Yes, ma'am.
Okay, so do you do it any differently, or do you agree with what Shakti has said? Do you agree that it has to be done with a 4 clamp or a 5 clamp ORFIT, right? A thermoplastic device. Then you acquire CT cuts from the vertex to just below the carina, right? Correct? Agree?
You need to answer whether we agree or don't agree.
Ma'am, sometimes we can take the entire lungs.
Why do you want to do the entire lungs?
Ma'am, just to screen for any lung mets.
Do you want to use your CT scan to screen for lung mets? See, I tell you, the way you answer, your examiner is also going to ask you questions based on that. You've done a complete metastatic workup. If you're suspecting lung mets, you will do something else. Why do you want to do it on your planning CT? Fine, so we leave that out. We do the loco-regional scan, right? Now,
Yes,
what is the importance of doing image fusion? Do you need to do it? Don't need to do it?
Need to do it.
Need to do it. So you agree? So what is the image fusion that you would use? Would you fuse your MRI, PET CT with your planning CT?
And we mostly use MRI in cases of intracranial extensions.
Okay, good. That's not a bad idea, but it would be ideal to fuse it otherwise also. Now in the chat, somebody had written that we use the PET CT for RT planning. Okay, and somebody had also answered that we give neoadjuvant chemotherapy to be able to reduce our radiotherapy volumes. So I want both these students to give me answers now. If you use a PET CT, what will you use the PET CT for in your radiotherapy planning? Komal and Asim, you'll have to tell me if I'm going overboard about radiotherapy.
No, ma'am, it's okay. Ma'am, the crowd has a lot of radiation oncology residents, so
okay.
Online crowd, ma'am.
It's brilliant to go back to the class.
Okay, fine. Thank you. And okay, now come on, go ahead. Tell me now. What will you do with the PET CT? What will you do with the? So that's the first question. What are you going to use? If I tell you, then I would also use the PET CT. Everybody has agreed with me that if you have an MRI, you prefer to use the MRI. But PET CT, what will you use it for? So Debanjan says that you will use it to delineate the lymph nodes. Now, do you have any guidelines to use PET CT for primary volume delineation in nasopharyngeal cancer, or for that matter in any head neck cancer? The answer is no, okay? But you could use it to give you an idea, all right? And especially if you have any kind of confusion about the extent of disease. But normally in the per primum setting, we don't use the PET CT for delineation, all right? Now somebody had also used, yeah, correct, Debanjan. Now somebody had also said that we use this, we could also use neoadjuvant chemotherapy to be able to reduce our our radiotherapy volumes. Now, whoever has said this, I first want to know from the other radiotherapy trainees, do you agree to this statement or don't agree to this statement?
We don't agree to the statement. We need to give radiation to the full baseline disease.
Okay. Now, whoever had told me initially that you can reduce volumes, do you agree to what he's saying? That you don't do anything, you give that full pre-chemotherapy volume, the doses that are necessary. Can you stand by the comment that you made?
Ma'am, we use the post-chemotherapy volume for as our GTVs, ma'am.
Really? And is there evidence for that?
I disagree.
Okay. Who agrees and who disagrees? Disagree wala banda bolo kyun?
I disagree, ma'am, because it's like NACT in a surgical this thing. You cover the entire field. You just shrink the tumor with neoadjuvant. You sterile the margins, but you go with the original margins as the tumor was. So dose reduction, in my opinion, doesn't sound logical to me.
So, okay, this surgeon who has told me this, now tell me, okay, now a surgeon has told you this. So how will a radiation oncologist justify You're reducing volumes. Vis-a-vis, you have the other school of thought saying that you don't reduce volumes. Yeah, tell me, is there evidence? What are your international guidelines for nasopharyngeal cancer?
We at all.
Yeah, so what do those guidelines tell you?
Ma'am, and we asked us to take the whole pre-chemotherapy volume.
Yes, so the guidelines suggest or rather recommend that you take the pre-induction chemotherapy volumes. But yes, there are people who are correct again here who say that perhaps you could go back to the post-neoadjuvant chemotherapy volumes. There are 2 randomized trials which have shown that there is no detriment done. But having said all this, I agree with the surgeon also. When you're giving neoadjuvant chemotherapy, the logic is that perhaps you're also leaving behind microscopic disease in those areas where there has been response. So you will try to cover those areas, and that's why the Lee guidelines tell you that you should go back to the neoadjuvant chemotherapy volumes. But at the same time, if you do the post-induction volumes, you have to be very careful and critical of what doses you deliver to what regions post-response. Ideally speaking, the volumes that were involved pre-neoadjuvant chemotherapy should receive doses that are necessary to tackle at least microscopic disease. So typically those volumes should receive a 16-30 equivalent or a 63-35 equivalent. All right?
Yes, ma'am.
Clear? Agree with me, Sambit, Shwetabh?
Absolutely.
Definitely, ma'am. Yeah.
Okay, so that's okay. Thank you. So this is what you would do. All right. So now somebody, can you quickly tell me what the Lee guidelines are? What are the 3 dose levels that they have recommended? I stopped Shakti here intentionally because I want those answers from you. Though he's already told them, you know.
City with low risk, high risk, and intermediate risk.
Okay, so what is the low risk dose level?
54, ma'am.
54 or
50.40.
So you have, so that brings me back to another basic question in radiation therapy. What is the guideline? How much of dose per fraction should you not exceed for the primary disease? 2.2. Okay, it's not 2.2, it's 2.1. So you don't exceed a 2.1 gray per fraction. But in that, you end up delivering 70.2 in 39, right? Because you have a 2.1, you have a 1.8, and you have a 1.7, 1.8, and then you have a 1.6, right? That's the Nancy Lee's thing. But if you talk about the Ann Lee's criteria, then you have a 70-35, 63-35, 56-35. Agree with me, all of you? Agree?
Yes, ma'am.
I don't hear anything. Now tell me, what are the structures that get included in the intermediate risk volume? In someone who doesn't have disease going all over the place. So traditionally, what have they recommended for the intermediate risk volume of nasopharyngeal cancer? What are the structures? Come on, someone quickly.
Posterior part of the nasal cavity.
Okay.
So maxillary sinus, posterior half.
Posterior half, posterior 1/3. There is a difference. Yeah. Okay. Fine. Then
cavernous sinus.
Bhaiya, wait a minute, ruko. For all stages, you will include the sphenoid sinus. How much of the sphenoid sinus? How much of the cavernous sinus?
Lower half, upper half.
Lower half, upper half nahi hota hai. When depending on the stage and if the sphenoid is involved, then the sphenoid is involved versus sphenoid is not involved. The extent of involvement, inclusion of the sphenoid will differ, right? If it's involved, you will include the entire sphenoid sinus. If it is not involved and just going superior to the floor, you will include the roof, you will just include the floor, right? What about the parapharyngeal spaces? On both sides. Hai ki nahi?
Yes, ma'am.
Hai na? Okay, so you have to know these structures and how much you have to include. So please go back tonight and read your ANLI guidelines. All right? Correct?
Yes.
Okay. Now, can you go ahead, Shakti?
Yeah. So like how ma'am said, the high risk volume and then the intermediate risk volume, which will cover the sites which ma'am has described. As you can see, the clivus, 1/3, then your maxillary sinus, 1/3, then laterally parapharyngeal sinuses as such. And their nodal volumes. Like,
okay. So now
And
this is
just one
63
more
grade.
question, ma'am.
Yeah.
To sum up someone from the radiation oncology group, in which part will you like to keep the 1B group of lymph nodes?
Yeah, that's a good question. Do you do it routinely or do you do it only sometimes? And when is that sometimes?
We don't need 1B in N0 disease.
1B and 4, we give only in N plus diseases.
So all N plus disease you will do 1B. Huh?
Does it have anything to do with N plus at which level?
You remember seeing Dr. Shwetabh's last slides on his general management? What were the levels that he talked about for nasopharyngeal cancer?
2, 3, 7.
What is 7?
Retropharyngeal. 7A
Okay.
retropharyngeal. 7B.
And what happens to 7B?
Retrocytoid.
Okay. Now what happens to level 5? And when do you do and when do you do level 1B? Come back to the question.
Level 2 include होगा तो मैम करेंगे level 1B.
पक्का हर level 2 include हर patient तो level 2 लेके तो आता ही है. 85% of your patients will come with level 2. तो हर एक में करोगे 1B? नहीं जरूरत है. ठीक है? या तो वो infiltrate कर रहा है submandibular gland को या फिर actually there are level 1B nodes which you see only if there is a thing if there is too much of lymphadenopathy, or sometimes when the structures that are involved that drain to level 1B are involved. Okay, go and read your Julian Biauka guidelines, all right, for the various nodal levels for different 1B nodes or even Anneli's guidelines. All right. Sambit, और क्या पूछना है? पूछो भाई before we go to Sambit, Shwetabh, anything else?
Yeah, that's it from my side, ma'am.
Shwetabh, anything else in nasopharyngeal? Sheetal, you want to ask something from the surgeons?
Ma'am, the master surgeon is not heard of. Dr. Pai is there, but not there.
No, yeah, he's a little busy, I believe. So he's attending this and attending something else, both together.
Not really, ma'am. But yes, 1B, in my opinion, is probably very, very rarely covered unless level 2 has encroached with ECS and involved and it's a conglomerate nodal mass. Otherwise, 1B is by and large spared.
Yeah, thank you. And I think Sambit made a very important point. Sometimes, your radiologist also talks about a level 2, which is very anteriorly located at the junction of level 2 and 1B without actually involving a 1B. So in those cases, depending upon how much of disease is involved anteriorly, you may want to include the 1B, but I would do that more in my prophylactic. But rarely ever do I do 1B otherwise in nasopharyngeal cancers. Okay. So now what happened, Shakti, to this patient?
So these are our, in terms of importance of organs. If you see, the brainstem spinal cord comes first, then comes your PTV, brainstem spinal cord and temporal lobe, then comes your PTV, and then your remaining structure. So he completed his treatment. So on treatment 1, we do an image verification with a CBCT with daily image guidance. This is how we routinely deliver treat nasopharynx. We do a bone-to-bone match, and fine with an auto match, and then patient is planned for treatment. And we do a response assessment at 10 to 12 weeks with a PET CT and an MRI, a DNE, and serum EBV titers. He had a complete response on PET and an MRI, and EBV was also not detected, and a DNE with no evidence of disease. And after this, he was kept on routine follow-up at 3 monthly intervals for the first 2 years.
So is that agreeable to everybody?
Yeah, I just want to ask, PET CT and MR both, why?
Yeah, so Shakti, can you defend what we do?
Yeah, so PET CT would give us information regarding the biological as well as the nodal disease status. As the MRI would also add on to our clinical findings for the local disease extent. The PET may not be the best place in terms of
so PET is being done for a metabolic disease residue, right?
Yes.
And MR will be done for a metabolically positive disease with structural availability.
Yes.
Yes.
So you're right there. So essentially what we've seen over these years is that MRI sometimes gives us morphologically stable disease, or tells us, can't distinguish very well between post chemoradiotherapy response versus just a morphological change. So we use the PET CT to kind of look at the metabolism in this area. Of course, today you can use diffusion weighted MRI sequences also to help you with this kind of response. So we use it because it gives us complementary information, and this becomes the first baseline scan rather after completion of treatment for comparison in future. So that's what we use it for actually. But
Okay.
Yes, you're correct. In some cases, you may want to do just an MRI and not do the PET CT. Yeah. Okay. I think there was a question in the chat boxes. What is the harm in including 1B? Now you tell me, why do you want to do unnecessary radiation? And also, if the disease is not going to spread there, why do you want to add morbidity? If you spare the submandibular salivary glands in this young boy,
Some saliva will be.
yeah, he's going to have a good quality of life. Okay. So you should, wherever possible, not do unnecessary radiation, especially if you know. See, nasopharyngeal cancer, unlike some things like the tongue and all that, you have a relatively very orderly spread of disease, and you should exploit that in treating patients, so that you can reduce morbidity. All right. Yeah, Hitesh, were you saying something?
Ma'am, one point I want to add.
Yes, madam.
Yeah,
if
please
there
go
are
ahead.
intraparotid nodes, especially in the tail parotid, which is just posterior to submandibular gland, in that case, would you involve level 1B?
If you have a node there, you would include that area properly. So in
it's a tail parotid node.
Yeah, so tail parotid will be your anterior 2 versus your lower 1B, So in that kind of a nodal situation, you may want to even include your superficial parotid lobe.
Correct.
In that kind of case, yes, you would.
So if there is a node in tail parotid, you would include the entire 1B, even submandibular gland?
You could, yes, depending upon what that node is, whether you're sure it is in the subparotid or it is in the level 2 or in the posterior 1B, you'd want to make that distinction.
Absolutely, man. Yes. Thank you.
Just one point to re-emphasize the point that ma'am said, that whenever we are treating 1B, and given the fact that a majority of the nasopharyngeal carcinoma tend to happen in age group which is quite young, and these patients getting a significant high dose to the mandible as well as to the submandibular salivary glands could result in a toxicity which is long-term and debilitating in a pediatric subgroup of patients. So we need to be very sure that in which scenario 1B has to be included and when it has to be left.
So next, what we've talked about follow-up. Do you do things differently? So essentially, Shakti has told us about follow-up and what we did, what we tend to do at our institute. Now, very importantly, another thing that you have to remember for this young patient is what? Tell me, one of you, both the surgeons and the radiation oncologists. This patient at follow-up, now he's got a complete metabolic response. Henceforth, how are you going to follow up this patient? He's 18 years old.
Textbook 6 months MR.
Then
resource constrained clinical examination and suspicious MR.
And what I'm looking for something else besides just his loco-regional imaging. One is to confirm that he is loco-regionally controlled. Besides that, what more are you going to do in this patient?
T3, T4, TSH, close follow.
Okay, okay. Then what else? You said about thyroid thyroid profile. Next, what else are you going to do? Shakti, don't give away answers, man.
Endocrine assessment.
Okay, so endocrine essentially what? So ideally, if you had all the facilities available, you would actually do a proper baseline hormonal assessment of the patient
Pituitary.
for his hypothalamo-pituitary axis, okay? Because this is a young boy. You would want to do all those things. So even at follow-up, you want to do it at least once in 6 months. But most of us have ready access only to the thyroid profile and we do it. But please remember, in young girls, in young males, you need to do the complete hormonal assay as and when necessary. All right. Please
Yes,
do not do and not pay attention to that. Besides this hormonal assay, what else do you have to look for and pay attention to in this boy?
Visual field testing.
Okay. What else? So your ophthalm evaluation you're going to do, and that is more important when you have disease that's going close to the optic
yes,
structures. Okay. What is the other very important thing that these patients come with?
Ear evaluation, hearing assessment.
Yes, very good. Hearing evaluation, very important. Okay. So now the surgeons tell me, what are the hearing tests that you will do? Please tell us all, the radiation oncologists, about what are you going to be doing for your hearing assessment.
So to begin with, the pre-treatment and post-treatment protocols differ. Pre-treatment, we will probably, if the patient presents with otitis media with diffusion, we'll do a topanometry, we'll do a baseline audiometry. Unfortunately, what happens is that with addition of cisplatin with multiple cycles, whether it is neoadjuvant or it is CTRT, these patients do have a tendency to develop SNHL, and they need to be rehabilitated hearing-wise. Now, that SNHL is irreversible. Whatever degree of hearing loss happens, it is very, very, very rare to recover. And these patients need to be rehabilitated in terms of their hearing. The otitis media with effusion probably resolves with the disappearance of the primary around the eustachian tube orifice, and probably a Grome may help, but that the conductive component is taken care of. The SNHL component, unfortunately, does not recover.
So then post-treatment, what will you do for these patients? You will do a PTA, or would you prefer to do an impedance audiometry?
Impedance audiometry, yes, as a baseline post-treatment once, because impedance by and large has a help for otitis media with fusion, or maybe detecting a conductive loss, or drum impairment, ossicular impairment because of fibrosis. But essentially, it is the cisplatin-induced ototoxicity.
Yes. So, so you have to keep in mind that besides the rehabilitation that you're looking for as for hormonal changes, you're also going to look at hearing, you're going to look at vision, you're going to look at dental, and then you're going to look at whether this patient can go back to work, go back and return to normal life, okay? Because this is a young adult, your chances of being able to cure him are pretty high. All right? Now tell me something, when will you send your patient who has a residual lymph node post-chemo radiotherapy to the surgeons, radiation oncologists?
As early as possible.
Really? Why do you want to do that in a nasopharyngeal cancer with an undifferentiated nasopharyngeal cancer?
As early as possible, I refer to the fact that once the post-RT effects are settled down,
fibrosis, you mean? Yeah, okay.
Yes, 6 to 12 weeks is an ideal time when a reassessment has to be done on the radiation oncologist part and on the clinician, on the surgeon's part.
Yeah. So here, na, Sheetal, I would beg to differ with you. Typically in nasopharyngeal cancers, worldwide and especially in the endemic regions, they wait almost up to 6 months for the neck especially. But yes, if at 6 months also you have a regressing node but has not regressed completely, your EBV titers are falling, so you realize that your disease is actually involuting, responding. So for nasopharyngeal cancers, you may not be in a hurry, especially if there is residual lymph node left, to refer across to the surgeon, provided the primary is controlled. But beyond this, if you still have a persistent neck node, please do not hesitate in referring the patient across to the surgeon, because there is a role for neck dissection in nasopharyngeal cancers also. And at that time, you may also want to evaluate the patient for perioperative brachytherapy if the facility is available. All right?
Yes, ma'am.
Okay. Anything else? Shwetabh, Sambit,
That was a
Sheetal?
learning, ma'am, because in my experience at institute, we generally follow 3 months. As you rightly said, that they keep involuting, and if the titers are falling, then obviously you observe. But if the titers are equivocal and the structural disease is there, it is FN positive for deposits, probably I would err at 3 months.
Yeah, fine. That's correct. I accept that also from you. Yes, surely. So any other questions, comments, inputs? So Asim, what do you want? Do you want Shakti to go ahead and make that little presentation on nasopharyngeal cancers?
Yes, ma'am. Ma'am, if it's a short presentation, I mean, it will get over in 10 minutes. I think we can proceed.
So Shakti, go ahead and present your thing about the nasopharyngeal cancers.
So undifferentiated cancers, if you look at the incidence, it's most common in the endemic areas, and in India is more commonly seen in the northeastern states, and it's also seen in some states of Bihar, Jharkhand as well, in terms of India. So as ma'am said, it's a nasopharynx is a cuboidal space, and the extension, as you can see from the place posteriorly, it can extend into your skull base, clivus, C1, C2, and then behind brainstem, laterally into your pterygoid muscles, anteriorly nasal cavity and paranasal sinuses. Superiorly, you have your sphenoid sinus and cavernous sinus, and through the cranial nose, and to extend where the cranial nose through the foramina. Then the T stage, if you look at it, it is exactly based on where the tumor is located. T1 remains in the nasopharynx, oropharynx, or the nasal cavity. And T2 is when it extends laterally, parapharyngeal. T3 when it starts going into the bones. T4 is when you have your intracranial extension, cranial nerve involvement, or it's extending beyond oropharynx into the hypopharynx and areas and orbit. And lateral extension is extending beyond the lateral surface of the lateral pterygoid muscles. And it, as ma'am said, there's a predicted pattern of spread even in terms of lymph nodes. You will see the retropharyngeal and level 2 group of lymph nodes. Very rarely you would find skip metastasis happening in nasopharynx cases. And similarly, the nodal stage, N1 is one EGCC staging where you have the N1 stage. There's bilateral, where bilateral nodes of retropharyngeal still come as N1. It doesn't go into N2. N2, you can have bilateral lymph nodes, 6 centimeters or smaller. And this is an important criteria. It's above the caudal edge of caudal border of cricoid cartilage. And N3 is any load more than 6 centimeters or extending below the caudal border of cricoid cartilage. Based on the T and N stage, you can go into the T and M staging. So an easy way to remember it would be that all N3 disease will go into 4B, 4A, and metastatic goes into 4C. And N0 remains at stage 2. Once you have node positivity and T3, it goes to stage 3. And there are multiple guidelines. The Chinese guidelines is also there. The European guidelines are there. As we described, we do a routine nasopharyngeal CBC, LFT, RFT, tumor biopsy with Iberish can be done. A CT or an MRI would be preferred as a local imaging or a CT and FDG as well. We also ophthalmic evaluation, a dental, since this patient is going to go for chemotherapy and radiation, an opthal evaluation and EBV DNA titers. And a rough overview is stage 1, in which it's node negative. You can treat with N0 definitive RT. In stage 2, it's IMRT definitive RT, a CTRT. In multiple guidelines, once they are node positive, usually the guidelines, most of the guidelines, plan of neoadjuvant chemotherapy followed by definitive CTRT is the routine management protocol in these patients. In terms of radiotherapy, IMRT is the standard of care. We know with IMRT we have better survival, and our neurological, all our toxicities are much lesser, especially our neurological toxicities. So IMRT is the standard of care for nasopharyngeal cancer. And is there a role when it comes to metastatic nasopharynx? Yes, there is a randomized trial which suggests an OS benefit even with patients with lung, bone, and liver mets. By giving loco-regional therapy, you're able to improve overall survival in metastatic nasopharynx cancer. And follow-up, as we said, each country has a different follow-up routine. What they routinely do is a 3-monthly MRI and a PET CT, 3 months after MRT, then every 6 months. Some institutes even follow 3-monthly MRI for first 2 years, and a DNA or a nasal endoscopy examination every 3 monthly, and EBV titers after completion of 3 months, 12 weeks after completion of RT, and then you can do it once more after a year, and an endocrine evaluation as well, at least once a year. And this is something, a checklist like we follow at TMH, which has required investigations, so that we can cross verify each and every step of our thing, whether we're going in the right path, and so that we can check everything is done. Thank you. This was my slides.
Thank you, Shakti. So are there any questions? Otherwise, I think we've overshot time, right? Are there any questions, comments, anything that we need, that you want to ask, say?
So I had a question. What will be the role of EBV titers in the post-op period? Does it have any clinical, treatment implications, or does it have only a prognostic implication?
Okay, so now the point is EBV has a role in the estimation of EBV titers in nasopharyngeal cancers can be taken up in various situations. It has a role in screening. It has a role in establishing a diagnosis, so pre-treatment, prognostication, monitoring of treatment, and of course, finally, again, prognosis. So pre-treatment screening, you have very high titers of EBV in the endemic region. Then you can do a directed nasopharyngoscopy and directed scans and actually detect lower stages of the cancer. For monitoring of response, it is a very good tool for monitoring of response, because if you've got persistent EBV titers 3 to 6 months after completion of therapy, you know that this patient is either not responding to treatment or has distant failure, even though there is complete locoregional failure. And you have trials that have adapted the use of adjuvant therapy based on what is the EBV titer post completion of your definitive part of the treatment. And of course, based on the EBV titers less than or more than 4,000, you can say whether this patient is in a good or a poor prognostic group. There's much more to the EBV business, but then this is basically what you need to know about EBV.
So ma'am, will it, suppose the EBV titers are elevated after the treatment. So will we do a PET CT if they're elevated, or we'll just do a...
We'll do a PET CT. We will also try to try and see whether this patient has got metastatic disease. Now, see the situation that I was kind of discussing. You've got a persistent lymph node. Your EBV titers are not going down. They remain to be high and they're rising. At the same time, you've done a PET CT. You've got disease nowhere else. That means this node definitely needs to come out. That is the kind of implication this persistent rising EBV titers would have. Also, if you know, the NRG HN001 is actually looking at how EBV titers can be used to adapt therapy and continue with adjuvant therapy post completion of chemoradiotherapy.
All right. So I think
I have one. Yeah, ma'am. Last one. Ma'am, at which point of time, in case of oligometastatic disease, you incorporate the SBRT, whether it is before the CTRT or after that?
So see, the evidence that you have in literature from those 2 randomized trials essentially talk about doing neoadjuvant chemotherapy, assessing response, and then doing loco-regional therapy, which has been shown to be beneficial. You really don't have overwhelming evidence for the treatment of metastatic disease. But what we do is that if you've got limited metastatic disease, what we tend to do is give the induction therapy, then do the CTRT. And when we are doing the CTRT, we do the SBRT for the oligometastatic disease. The reason being that we want to, make it the logistics essentially. So we do the SBRT when we are doing the CTRT. The reason I don't do the SBRT upfront is because unless there is cord compression, impending fracture, those are different situations. But otherwise, in the routine oligometastatic disease, we usually do induction chemotherapy followed by response assessment and then loco-regional RT together with the RT to the metastatic site, provided that metastatic site is treatable. That's what we usually do.
Yeah, I'm just talking about post-induction therapy.
Yeah.
Whether to go at SBRT first or CTRT, local
We do
regional
it
CTRT.
together. We do it together.
Okay. Okay.
Or we do it in the last 2 weeks of the loco-regional RT.
Yes.
Ma'am, there is a question like, what is the opinion regarding optimizing dose to dysphagia structures during chemoradiation?
So this question, actually, I think Shwetabh tried to address it in his presentation. The point is that here in nasopharyngeal cancers, if you're going to treat your volumes adequately, you will not be able to spare your superior constrictors, because if you try to spare your superior constrictors, you are going to underdose your retropharyngeal lymph nodes. Also the primary sometimes, because essentially, if you see, most primaries would be in the midline, or you would have to include the entire nasopharynx in most cases. So here, what you can definitely spare in most cases is the middle and the inferior constrictor muscles. You should not try to spare these structures at the cost of underdosing your target volumes. Also for this, I would refer you to read the paper from Anley on the international prioritization, whatever that is, that paper which talks about all the priority levels for the different structures that you need to. So if you look at that paper, this will fall in priority 5. Yeah, anything else?
Ma'am, I had one more question. If you have a carcinoma of unknown primary node, single node is there, and on that Eberish is positive. So ma'am, what will be your fields of radiation in that?
Shwetabh, Sambit, answer, man.
The EBV is positive in this case.
Yeah, nasopharynx DNA is negative, EBV positive node in the node.
So we would like to take the nasopharyngeal part in the larger field area, and taking that as the occult metastasis with secondary neck node in any level 2, level 3, whatever it is, and the uninvolved lymph nodes and rest oropharyngeal region, we can keep it in the lower subgroup, that is the 54 gray or 54 to 60 gray subgroup.
So nasopharynx bilaterally will be included in the fields, or
yeah, bilaterally.
All right. I think, ma'am, that's it. I think it's time that we conclude the session. Thank you, ma'am.
I get carried away with nasopharynx, yeah.
Thank you so much for such an elaborate discussion, and it was great to hear from the greats. And I would also like to extend my thanks to Dr. Shwetabh for such an elaborate presentation, Dr. Sheetal for giving the surgeon's perspective, and Dr. Sambit for his contribution. We'll come back again, and Dr. Shakti Keval also for making the presentation and presenting it quite well. We'll meet again after 15 days with a new topic and a new set of examiners and a case. Thank you so much to all the participants, and I hope it has been a learning lesson for everyone. Thank you.
Indeed, and thanks, Sarbani ma'am, for being the part of the panel.
Yes,
Thank
definitely.
you. Thank you for
Always-
the kind invitation, Asim and Komal.
It's
And it was
always
a
fun to
pleasure
learn
being
from
here.
you. It's always
Thank
fun
you,
to learn from you.
It was a pleasure being here. Chalo. Thank you. Bye-bye. Good night.
Good night, ma'am.
Thanks.